Hi, I'm Chul-min Lee, and I'm going to present our study titled How to Combine Diffusion-Weighted and T280 Imaging for MR Assessment of Pathology Complete Response to Neoadjuvant Chemoradiotherapy in Patient with Rectal Cancer. Preoperative chemoradiation therapy is standard treatment for rectal cancer at a high risk of recurrence after surgery. 10 to 25% of patients achieve pathology complete response (pCR), which means no residual tumor. Watch-and-wait approach means patients with pCR after CRT could be managed with careful regular surveillance, and it could avoid surgical complications, perioperative morbidity and mortality, and the need for permanent stoma. Therefore, accurately identifying pCR to CRT is important. In the MR evaluation of CRT response to rectal cancer, T280 imaging is widely adopted in clinical practice, and addition of diffusion-weighted imaging might improve MR accuracy. However, optimal combination of T280 imaging and diffusion-weighted imaging for maximal efficacy have not been established. Therefore, we aim to determine an algorithm for combining T2 and the diffusion-weighted imaging to optimally diagnose pCR to CRT in rectal cancer. Among the patients who underwent long-course CRT and high-resolution MRI before and after CRT, 376 patients with reference standards for CRT response were included in this study. 69 patients were confirmed as pCR, and remaining 307 patients were diagnosed as non-pCR. Because of the high degree of inter agreement between two radiologists prior to main analysis, we randomly divide the study patients into two groups, and each reader analyzed one group. We interpreted T2 and diffusion-weighted imaging where the visible tumor signal was absent or present. T280 imaging was reviewed first without diffusion, and then, using T280 image result as the reference standard for location, the readers interpreted diffusion-weighted imaging. We also evaluated a subset of patients who showed homogeneous hyperintense signals throughout the tumor on diffusion-weighted imaging before CRT. We evaluate three different methods of combining T280 imaging and diffusion-weighted imaging. First, if both T2 and diffusion were CR, it was defined as AND combination. Second, if there was CR on T2 or diffusion, it was defined as OR combination. Finally, if T2 were CR or diffusion were CR and homogeneous hyperintense on pretreatment diffusion, it was defined as conditional OR combination. We compared the sensitivity and specificity of three combination methods for diagnosing pCR with T280 imaging alone. Then the numbers of true positive and false positive diagnosis of CR were compared across each combination. Compared to T280 imaging in AND combination, the specificity increased significantly while the sensitivity decreased without statistical significance. On the contrary, both OR and conditional OR combinations resulted in significantly large increase in sensitivity and large decrease in specificity. AND combination made false interpretation of CR in 10 fewer patients and failed to demonstrate pCR in 2 additional patients. On the contrary, both OR and conditional OR combination made additional false interpretation of CR much more frequently than they identified pCR. This is an example of diffusion-weighted imaging, demonstration of non-pCR, undetected by T280 imaging. Post-CRT T280 images show a remarkable decrease in the tumor with the remaining hyperintense thickening of the wall without visible tumor signal, whereas diffusion-weighted image shows a residual tumor signal. Pathology analysis showed non-pCR. This is 1 out of 10 cases of false positive reduction by AND combination. The next case is an example of false diffusion signal in a pCR. Post-CRT T280 images show a resolution of the tumor with the remaining thin, hyperintense scar on the luminal side. Diffusion-weighted image shows a nodular diffusion restriction. However, pathology analysis performed 13 days after showed pCR. There were only 2 such cases of true positive reduction by AND combination. AND combination is a appropriate strategy to capitalize the characteristics of the 2 MR techniques. There were minor loss in true positive which were exceeded by the much greater reduction in false positive interpretation of CR. On the contrary, both OR and conditional OR combinations showed a large number of false positive, which eclipsed the much less increase in true positive interpretation of CR. Furthermore, the probability of a spurious diffusion signal to mimic a residual tumor is likely quite low once the patient has been cleared of residual tumor through T2-weighted imaging. The reader's experience is important. We should try to avoid incorrect interpretations of diffusion-weighted imaging, mistaking artifactual signals for residual tumors such as T2 shine-through effect, a signal from a different location than the former tumor site, or susceptibility artifact. Therefore, diffusion-weighted imaging may play a role as a supplementary tool to T2-weighted imaging instead of being used alone to further exclude patients with the remaining tumors after they have initially been screened using T2-weighted imaging. This is a conservative approach considering the oncology safety of the watch and wait management. In conclusion, in adding diffusion-weighted imaging to T2-weighted imaging, and the combination is an appropriate strategy for MR interpretation of CR using visual assessment, as the combination most correctly false diagnosis of CR while nullifying only a few correct diagnoses of CR on T2-weighted imaging. Thank you for your attention.